You may not have heard of arteriovenous malformations, but AVMs, along with aneurysms, are the two commonest causes of brain hemorrhage, especially in children and young adults. Let's begin by looking at some normal vessels. What you're seeing here is a casting of the arteries supplying a single brain hemisphere. Those arteries look small and delicate, don't they? But they're not. They're robust. They have thick walls. Think of it. Only a few pounds of brain gets 20% of the heart's output of blood each minute. Fortunately, in the last decade, we've been able actually to see these vessels non-invasively using current CT scanners. Here's a normal brain angiogram. The white vessels are arteries. The light gray are veins draining the brain. Now let me show you an angiogram. Look at this unusual collection of vessels. This is an arteriovenous malformation. Unlike normal brain arteries, the blood vessel walls here are extremely thin, often develop aneurysms, and are prone to rupture. Let me next show you our standard physician training model, a simulator which mimics those abnormal vessels. Pulsatile blood flows in from the 5 o'clock position, passes through the ovoid malformation, and then out the vein back into the circulation at the 9 o'clock position. And yes, this is what happens all too often if malformations are not discovered and treated in time. Contrast that with one of our AVM study patients. Fortunately, her seizures brought the AVM to light before it had bled. This is a side view of the vessels at the back of her brain. Once you've seen one AVM, it takes no medical education at all to recognize another. The arteries appear black because we use X-ray contrast agent to make them show on the fluoroscope. Now, about 6 minutes later, following the injection of Neucrylate AVM, the nidus is completely filled and the stealing of blood from normal brain has been stopped. Think of it, only 6 minutes. Let me show you another patient. Sadly, this 36-year-old male was not so lucky, and his CT scan shows us this white egg-shaped hemorrhage, and it's in his visual pathway. Here's his diagnostic catheter angiogram. We're looking at his skull from the front. You can notice the shadows of his eye sockets. The surgeon treated 3 separate feeding arteries to his malformation. A total time of only about 12 minutes. 12 minutes. Now let's go back to our simulator so I can show you how we train physicians and how the material behaves. The artery is entering our visual field from the 6 o'clock position and passing up. You can see the microcatheter at the beginning of the malformation. The black dots are markers on it. Then there's the malformation, and then the vein drains up toward the 12 o'clock position. I should tell you about electronic subtraction. Every time the picture gets gray, the surgeon has done what's called a subtraction mask. The electronics of the fluoroscope allow us to make a mask and then electronically subtract away anything that we don't want to see. In this case, we're now able to see only the device, Neucrylate, coming in. As you watch this treatment in real time, let me explain. Pulsatile anticoagulated sheep blood is moving through the simulator. The same catheter we would use in humans has been placed into the circuit. In a human, we would place this catheter into the groin artery, then using the fluoroscope to guide the catheter into the vessels supplying the brain. Then, through that larger catheter, we place a microcatheter. Then, using live fluoroscopy, the surgeon can direct it up into the brain and up into the AVM nidus. Here the surgeon has made a new subtraction mask, and the black material is the new Neucrylate that he's continuing to inject. Now you'll see the surgeon turn off the subtraction so we can see the total extent of the Neucrylate. We use gold for opacity because it has an extremely high atomic number and is very efficient at attenuating the X-rays. Being able to see well is the key to safety in treating these lesions. Well, there's the completed treatment and the training. Half a dozen more of these, and his first patient will be done with minimal risk. Far better than practicing on a live human, isn't it? This AVM Neucrylate has been specifically designed to treat arteriovenous malformations. Neucrylate AVM has the same base monomer as our aneurysm device, but has been completely modified to optimize treatment for brain AVMs. As you see on the vial, it's colorless. It has the viscosity approximately that of kerosene, so it passes easily through microcatheters. It begins polymerization immediately upon contact with blood or blood vessel walls, and gives the surgeon the kind of control that you see and have seen in the patients and in the simulator. Currently, there are 2 other liquid embolic devices that are available to us. The first of these has been around and has not been improved, I should say, since the early 1970s. The second, ethyl vinyl copolymer, a ground-up solution of plastic particles dissolved in dimethyl sulfoxide, is currently approved for treating AVMs that are to be removed surgically. It takes literally 30 to 60 times longer to treat a patient with that device than a Neucrylate AVM treatment. And so you get a corresponding increase in radiation dose to both operator and patient. Most importantly, we now have CE mark approval to sell this device in Europe, and we have closed our clinical trials both in Budapest and in Tehran. Better yet, the regulatory paperwork is underway to begin sales in Central and South America. If you have further questions, please call us at 858-643-1675, 858-643-1675.